Hello friends, and welcome to Sterile Field Guide, a podcast dedicated to medical student general surgical education. I'm Alex, and I'll be your guide. Hello friends, and welcome back. This is episode 18, and in this episode we are going to continue talking about anesthesia topics, switching our focus to critical care. And so we are going to begin by talking about something that will come in handy in almost every single rotation that you do, regardless of if it's surgery, and that is pressors. So pressors are, if you've never heard of a pressor before, it is essentially a medication that is going to work in one way or another to improve your blood pressure. And some pressors are inotropes, but not all pressors are inotropes. And an inotrope is a medication that is used to increase the contractility of your heart. And so some inotropes are also pressors. Not all inotropes are pressors. It kind of is a two-way street. So we are going to talk mostly about pressors, but we will begin talking about inotropes. Just be familiar that those are two different things, and I will be using those terms pretty heavily in this episode, so just so that you are aware. We are going to talk about the physiology of these different pressors, which can help you when you are in a clinical situation to choose the correct pressor for that specific situation. So to start out, thinking very broadly about the pathophysiology of a pressor in general before we go to the specific receptors, we can think about our vasculature like a hose. So a vessel is like a hose. And a pressor is going to help to constrict that hose. So almost as if you put your thumb at the end of the water hose when you were a kid, and that helps it to spray. So narrowing the lumen is going to cause that to flow under more pressure. That makes sense. However, something to consider is that if your hose is only half full, so if you only have the faucet turned on a little bit, putting your thumb over the end of it is not going to cause an increase in pressure because there is not enough to fill the tube in the first place. So this is something that comes in handy when you're thinking about giving a patient a pressor, is that if their tank is not full, so if they are volume down, they're hypovolemic for some reason, very dehydrated, have lost a lot of blood, etc., for whatever reason, they are in a shock state where they need a pressor. If they do not have enough fluid, you also need to give them fluid. Giving a pressor is not going to increase blood pressure if there is not enough fluid in the system to press on, if that makes sense. So that is something to think about. I think people often forget about volume status as something that goes into shock. And so as a medical student, when you start thinking about that and when you are giving pressors, especially when people are in shock, making sure that you have an eye on their fluid status. And for some people, whether it be cardiogenic versus something like hemorrhagic shock, giving fluids versus not giving fluids and what types of fluids you're going to choose is going to be a totally different discussion. But just know that you cannot increase pressure if there is nothing to squeeze. So make sure that your patients are getting blood or fluids or have optimized their volume status at the same time that you are giving these pressors. Just an aside on fluids. So if you need to give fluids, do that. And we will talk about shock and resuscitation of shock in a separate episode. And we can also talk about fluids and fluid resuscitation in a separate episode because those are complicated things in and of themselves. But something to think about is fluid is not always the answer. And so this is a little life lesson, I guess, that I can share with you. Everything that you do has a consequence. And one of the things that has consequences is giving fluids. So some common complications of giving too many fluids is that patients can become volume overloaded, and volume overload in patients who have cardiac disease can be really devastating. But even in patients who are healthy, if they become volume up, they can get pulmonary edema. They can have an increasing oxygen requirement. This can be really terrible for patients who already don't have a ton of respiratory drive and can even cause ICU admission, bordering on needing intubation and things like that. So giving fluids has consequences. It is not like a get out of jail free card if you just want to try some fluids in a patient. So just think about that as you're thinking, like I mentioned, like, oh yeah, you can't press on an empty system, but it's not something that you want to be loosey-goosey with. You do need to pay attention to that. Okay, so let's talk about the physiology of vasoconstriction super quickly. These are going to be receptors that you likely encountered in your step exams. If you haven't taken them, that's fine. This will be a helpful review for you. So for alpha 1, we're going to talk about the alpha, the beta, dopamine receptors. There are others. There are plenty others, and it gets complicated, and I'm not going to go over all of it, but this is your reminder that if you need more in-depth of a review of the physiology of these receptors, to go back through your materials and review them. But alpha 1 is going to induce vasoconstriction. This is located in vascular walls. It's present in the heart, and it can increase the duration of contraction, but doesn't necessarily increase the rate of contraction, which is chronotropy. For beta 1, this is also located in the heart, and this is important to note because beta 1 is going to come up when we're talking about inotropes, and it's going to come up when we're talking about vasopressors that are also inotropes. So beta 1 is active in the heart. It can cause inotropic and chronotropic effects, so cause more squeezing and faster, but it causes minimal vasoconstriction. So true beta 1 is going to be an inotrope. True alpha 1 is going to be a vasopressor or a pressor. Together, they are both. Beta 2 is going to cause vasodilation. This is something that we target when we're giving epinephrine, and we'll talk about that a little later, but vasodilation, bronchodilation, those sorts of things with beta 2. Dopamine, these receptors are complicated, and we will talk about how the administration of dopamine as a pressor is very dose dependent, and depending on the dose you're giving, you are targeting a different receptor. And so it is really complicated, dopamine is, and so at a low dose, dopamine is going to work on dopamine receptors. These are present in the kidney, in the mesentery. You also have cerebral and coronary receptors, and this causes vasodilation. Some people also postulate that targeting the dopamine receptors can cause increased urine output. At a medium dose, it targets beta 1, so that is going to cause inotropic and chronotropic effects. But it also, at the same time, is going to work on this dopamine. So these are additive. So at a medium dose, you're going to have dopamine and beta. At a high dose, you're going to add alpha 1 onto that. And so you're going to have vasodilation from the dopamine. You're going to have increased cardiac output with the beta 1. And then when you add the alpha 1, you're going to have increased systemic vascular resistance. So it's going to overcome the vasodilation from the low dose dopamine. And you're going to have vasoconstriction, but you are at a high risk of arrhythmia. So we will talk about all of this in more detail, but those are sort of the receptors to think about. So quick review, because I know that's a lot of information. Things to think about when we're talking about pressors and inotropes. Alpha 1 is going to be a pressor. So alpha 1 is going to cause vasoconstriction. This is going to increase your systemic vascular resistance and hopefully increase your blood pressure. Beta 1 is going to cause increased contraction and strength of contraction of your heart. And so this is going to be an inotrope. Beta 2 is going to cause vasodilation, bronchodilation, those sorts of things. So often is going to act sort of in the opposite way that we want when we're thinking about a pressor, but can be helpful for things like an allergic reaction or anaphylaxis. And then dopamine is complicated. It works on all sorts of receptors, and we'll go over it in more detail. We are familiar with the concept of pressors now and also inotropes, but when we're thinking about choosing a pressor, we're going to think about the clinical picture that's happening in front of us. And so if a patient needs their heart to beat and also needs systemic vascular resistance to be up, so they need all of these things to be working a little bit better for them, you're going to choose something that has alpha 1 and beta 1 in it, if that makes sense. So we'll go over the specific drugs and how to make a good choice, as well as the most popular drugs after we talk about the proper administration of pressors. So in the operating room, pressors are often given intermittently through peripheral IVs, and oftentimes in the OR, Patients will need pressors for many different reasons. Most patients that I've seen honestly have needed pressors after propofol induction. Patients just have a pretty profound drop in their blood pressure after propofol, and they respond very well to a little bit of pressor. And so you can give pressor through peripheral IVs. And also, if you're going to be giving something a little bit more substantial, you can give that through a peripheral IV with constant monitoring, like what is happening in the OR. But when you're thinking about something more long-term, pressors need to be given through a central line. So either long-term or high dose needs to be given through a central line. If you're not familiar with a central line can be a subclavian line, an internal jugular vein line, or femoral vein line. So subclavian, IJ, or femoral. We can talk about lines, tubes, and drains in a separate episode, but the reason why you need to give pressors through a central line is because these medications cause vasoconstriction, and long-term vasoconstriction in peripheral vessels can cause vasoconstrictor-associated limb ischemia, where patients can have ischemia of the digits, need amputations, they can have terrible necrosis of their hands and lose their hands when they need pressors for some other reason. And so we want to be mindful of what we're giving through peripheral IVs. There are plenty other medications that can be caustic in veins that we try not to give through peripheral IVs. And we can talk again in another episode about what central lines are used for, what medications you would want to give through a central line instead of a peripheral IV. But just know that for pressors, you're going to want, if you know that your patient is going to need pressors for a long time, or you think that they're going to need pressors for a long time, you're going to want to get some sort of central access on that person. And if you have a patient who is moving down a road of needing a little bit of pressor on the floor or step down unit, if your hospital does that, and they're moving to a place where they're consistently needing that, something that you can bring up is the need for central access, which sometimes will buy you an ICU admission, but it just depends on how your hospital works. But just know that it is safer to give through central access. It's also important to recognize the goal of your pressors. And so when we think about blood pressure, we're typically targeting a mean arterial pressure, or MAP, greater than or equal to 65. This is typically the target that you are aiming for, but this can change depending on the clinical picture, typically greater than 65 with a few exceptions. So make sure that you are aware of the MAP goals for your patient in particular. This can change with like vascular injury, especially like aortic injuries can have different MAP goals. Patients with really bad head injuries can have different MAP goals. So just make sure that you are aware of their MAP goals. And MAP is influenced by cardiac output and systemic vascular resistance. So we know that pressors are going to increase SVR, and we know that cardiac output can be increased by inotropes. And so you can really hone in on those different properties and sort of target what you're looking for as long as the patient is responsive. Something else to note about pressors is that they can decrease the uptake of medications that are delivered subcutaneously. And this makes sense because if something is delivered subcutaneously and it somehow works systemically, we would expect that it would be taken up by something and delivered to the body. And probably these things that are taking it up are eventually relying on blood vessels to carry it centrally and then distribute it to the whole body. And so if you are constricting down on vessels and trying to have a medication be taken up by vessels, it may be slower or you may have less uptake. So that's important to recognize when you're giving subcutaneous meds such as heparin, such as insulin, etc., that you may have a little bit more trouble with uptake or have some different effects when you are giving a patient pressors. Okay, so now let's talk about the specific medications that you may run into, starting with the crowd favorite norepinephrine, which is also called Levophed in the hospital. So a lot of your patients will be on Levo, quote unquote, Levo drips, or just Levo, Levophed, also norepinephrine, all the same medication. Norepinephrine is a godsend because it works on alpha-1, so it causes vasoconstriction and increases SVR, but it also works on beta-1, so it causes that inotropy that we are looking for. So In summary, norepinephrine causing vasoconstriction and increased cardiac output. Something to know about norepinephrine or Levophed is that it can have reflex bradycardia. And so some patients may have a modest decrease in their heart rate while they're on a Levophed drip. So if patients have like a prohibitive bradycardia, so if they're super duper duper bradycardic, norepinephrine might not necessarily be the best choice for them. This is the pressor used for septic shock. This is the recommended pressor when patients are in septic shock. And we, again, will talk about treating shock, different resources for shock. There's like a ton of literature out there that you should start to be familiar with as you move into closer to being a doctor or resident. Norepinephrine, the pressor for septic shock. So you will see a lot of Levophed / norepinephrine / norepi / levo while you are on the wards. The next one that we want to talk about is phenylephrine. So phenylephrine is alpha 1 only. So this just works on peripheral vasculature, does not work on the heart at all. This causes vasoconstriction. This also causes reflex bradycardia. And phenylephrine is very, very commonly used in the OR. Like I mentioned before, a lot of patients have hypotension induced by propofol. And the way that propofol works is it can cause vasodilation. Also, inhalational gases can cause vasodilation. So patients can have hypotension that is caused by vasodilation. And an awesome response to that is a targeted vasoconstriction. And so these patients don't need more of their heart to squeeze. The problem is their veins are blown out. And so phenylephrine, being alpha 1 only, can cause squeezing of that and reverse the impacts of propofol as far as vasodilation goes. If your patient has bradycardia, you can use something else. So if phenylephrine causes reflex bradycardia, which can be pretty profound or profound enough where your patient is under anesthesia and you don't really need them to drop their heart rate. If your patient has bradycardia at baseline or you're worried about them dropping their heart rate even lower, you can use ephedrine instead. Ephedrine works on alpha 1 and beta 1. This works by indirectly causing norepinephrine release. And so if your patient is catecholamine down, so if they for some reason have some sort of adrenal disease or they are not able to make catecholamines or they have stormed forever and are like out of catecholamines, ephedrine is not going to work for them. But the reason this is used, especially in the OR, again, for propofol-induced hypotension or inhalational gases, any sort of vasodilatory medication-induced hypotension, is that this choice does not have reflex bradycardia. So you can use this in patients who have bradycardia at baseline or you don't want them to drop their heart rate even lower. So summary of those two medications, this is sort of like Venn diagram. Both of them can be used for the problem of true vasodilation. Phenylephrine works only on alpha 1. This is just going to cause us a little bit of a squeeze. And phenylephrine does cause reflex bradycardia. So you would not choose it in a patient whose heart rate is already too low or you're worried about it dropping lower. Ephedrine works on alpha and beta 1, so it can help to support the heart rate response that you would normally see with phenylephrine. So ephedrine, alpha 1, beta 1. This indirectly causes norepinephrine release. So again, if you're catecholamine down, it will not work. This does not have reflex bradycardia, so you can use it for patients who are bradycardic or you're worried about their heart rate dropping lower. I know that's a lot of information, but that's important to recognize, especially if you're going into an anesthesia rotation. Okay, let's talk about dopamine. We started talking about this. It's fairly complicated. I'm not going to go into the doses, but I just want to do like broad concepts of how dopamine works so that if you are in a clinical scenario, you both know how to recommend the use of dopamine, what dopamine is used for, and also can recognize if you did an up-to-date search or some sort of pharmacology search, you could figure out what dose you would need for these things. But big picture, I want you to know that dopamine can be used as a pressor, but it has different effects on different receptors at different doses. So you have to pay attention to the dose that you are giving, because if you just give any dose willy-nilly, you're going to be working on receptors that you might not mean to, which could have the opposite impact that you're looking for. So for instance, low-dose dopamine works on dopamine 1 receptors, and this causes vasodilation. So if your patient is hypotensive and you add dopamine on at a low dose, you are going to cause more hypotension. So dopamine at a low dose works on dopamine receptors. These are present in renal, mesenteric, cerebral, and coronary beds. This causes vasodilation. At a medium dose, you're going to add on beta 1 activity. So you're still going to have dopamine 1 activity. You're going to add on beta 1. So now you still have vasodilation from the dopamine, but now you're going to have increased cardiac output from the beta 1. Okay, so medium dose is going to be dopamine, beta 1. At a high dose of dopamine, this is where you start to have more of your pressor activity. You're going to have your alpha activity, and this is going to sort of override the dopamine vasodilations. You're going to have some increased systemic vascular resistance, but at a high dose of dopamine, there are risks. So you have increased systemic vascular resistance, you have increased cardiac output, so now you're sort of doing what Levophed would do for you. So side effects of dopamine are that at high doses, you have a high risk of arrhythmia. And so that's important to recognize. And a reason that you would choose dopamine over norepinephrine is that, again, we talked about norepinephrine or Levophed having reflex bradycardia. So if patients have bradycardia and you don't have a way to support it, or it's not safe to support it in some other way, you can choose dopamine instead of norepinephrine. Okay, finishing up our pressors with epinephrine. So epinephrine also works on a variety of receptors. It works on beta 1, which is going to have that increased inotropy, so heart is going to squeeze better. It works on beta 2, so it's going to cause that vasodilation that you're looking for, but this is selective, as well as bronchodilation, so it's not going to be systemic vasodilation. It also has alpha 1 activity. So in summary, epinephrine is going to cause increased contractility of the heart. You're going to have overall vasoconstriction from the alpha 1, and you're going to have bronchodilation from the beta 2. And so this is super helpful in patients who are in anaphylaxis and have airway swelling. It's going to cause those airways to open up. This is really helpful in patients who are in cardiac arrest because it's going to kickstart their heart as well as give them some squeeze, give them some blood pressure. So epinephrine can be used for a variety of things. There's a such thing as a quote-unquote code dose of epinephrine. You can give epinephrine again for anaphylactic shock. You can add epinephrine on to an already complicated pressor regimen. One thing about epinephrine is that epinephrine can cause splanchnic vasoconstriction, and this is true for other pressors such as norepinephrine and dopamine, but it is worse with epinephrine. And so after, for example, belly surgery, not ideal to have a patient on pressors, and even less ideal to have a patient on epinephrine because you're going to have that vasoconstriction of the splanchnic vessels and less blood flow to your bowels, etc. And so that's not ideal. And so be paying attention to if your patient is on pressors. And this is something that I check for without thinking about it in every single patient, every single time I round, looking at the flow sheet, looking at their continuous strips. You can, at least in Epic, you can see like how many mics of norepinephrine were they on overnight. Okay, it was 3 at midnight and then it was 15 this morning. What happened? So looking at the trend of how much pressor they're on, looking at when their pressors were started, when they were stopped, if it correlates with anything, is something that you can do when you're chart checking. Some inotropes that you might want to be familiar with as we wrap this episode up are dobutamine and isoproterenol. Dobutamine is going to work on beta 1 more than beta 2 and also has some alpha 1 activity. Overall, dobutamine is going to cause vasodilation and increased cardiac output. Most frequently, this is used for medically refractory heart failure and cardiogenic shock. This is not used in sepsis due to the risk of hypotension with the vasodilation, although, like we mentioned, for cardiogenic shock and can cause your heart to squeeze better, which is part of the issue of cardiogenic shock. Tune in next week to talk about different kinds of shock and their treatments. Isoproterenol very quickly works equally on beta 1 and beta 2, iso meaning same. This is going to cause increased cardiac output and overall vasodilation. So this is also a choice for cardiogenic shock. And this has been a super quick overview of pressors. There is so much more to know about pressors. There are so many more drugs, many ways that you can use these, but hopefully this is helpful for you to start thinking about pressors and critical care. And I hope that you learned something, and I'll talk to you next week. Bye. That's it for today's podcast. You can support this podcast and receive exclusive educational content on Patreon and find us on Instagram at Sterile Field Guide. Questions and requests can be submitted to our Gmail at sterilefieldguide@gmail.com. Thank you for listening, and until next time, may your retraction be superb and your suture tails be the perfect length.